So I had a go at this. It went fine, but it was 17 minutes long and YouTube were being arsey about it. So, organs of the urinary system, there's 4, right? You've got your 2 kidneys, you've got your ureters, your urinary bladder, singular, your urethra, singular, that's longer in men. Why would a patient in renal failure have a low hematocrit count and be considered anemic? Dead easy, the kidney produces EPO. If it produces EPO, that drives erythropoietin, damage of the kidney, boom. Function of the kidneys, a wet bed. That's it, so we'll come to that. That's this, mnemonic, so acid-base balance, proton versus bicarbonate, water, electrolyte, toxin removal. And then bed is blood pressure with RAS, E with EPO, and D is calcitriol. Define the osmolarity of a solution and calculating it. Number of total step dissolved in particles. Number of particles dissolved per litre of solution, basically. In relation to the peritoneum is SAD pucker, which is suprarenals, aorta IVC, second and third bits of the duodenum, pancreas, ureter, ascending descending colon, kidneys, esophagus, rectum. Surface anatomy of the kidneys is T12, 12, 2 to 3, right being lower because of the liver. So you're thinking about the fracture risk because ribs 11 to 12, not 12 to 13. We don't have a supernumerary inferior rib there. Can fracture. Renal hilum is the bit, it's basically the conduit, where the ureter emerges with the blood vessels, nerves, lymphatics. 3 layers covering the kidney. So we've got a capsule on the outermost portion of the cortex made of dense connective tissue. We've got an adipose capsule, and then we have a fascial connective tissue, which is stronger inferiorly and weak, strong superiorly, weak inferiorly, which is why we can have drop at the kidney. There is a lot more detail, paranephric, perinephric, all these different kinds of fascial layers and things that you don't need to know unless you're an anatomist. That's a really good slice through the L2. You can see the 3 different layers. So you've got layer 1, layer 0 basically, the parenchyma of the cortex, the medulla. Then you've got the capsule of connected tissue, you've got adipose tissue, and then you've got the renal fascia, and then further out here you've got visceral peritoneum, basically. What is the renal fascia deep 2? Just said. Path of urine. So it's the collecting duct through the papillary duct, the 2 calyces, the renal pelvis and ureter, closely followed by the urinary bladder. You've got your obvious nephroptosis, floating kidney. The ureter can kink, which may block urine passage and put pressure on the kidneys, damaging the tissue. Now there are 3 major sites of constriction: the uteropelvic junction, the pelvic inlet, and the entrance to the bladder. So those are 3 good points to remember. Boom. 10 times more common in female. A quarter of us have weakening of that fascia, so there'll be some inferior displacement or risk of nephroptosis. 2 major regions of the kidney's internal structure: cortex, medulla, as per. Contents of the medulla. Now the medulla are the pyramids. They're not the the juxtamedullary columns. Those are projections of cortex. So they're not the medulla, it's just those pyramids, with the apex toward the renal hilum, where we get the papillary duct. So we get the papillary duct coming in, loads of collecting ducts form a papillary duct, empty into the minor calyx, which empty into the 2 or 3, the few numbered major calyx, then into the single renal pelvis. So, cortex is basically everything else. It's that outer cortex, and then those renal columns either side. Parenchyma would be the cortex of medulla. The functional kidney unit is, of course, the nephron. What happens to form urine? We've already said. It drains from the collecting duct to the papillary duct to the minor and major calyces, and it's urine after the collecting ducts, right? So once it's left the duct and it's not doing anything else, so in those calyces, it is that. Now this is good. We're not going to go through this, so pause this, have a guess. I'll skip ahead, and I'll skip ahead to the next one because that's the blood supply, basically. In a nutshell, it's renal artery, right? Segmental, interlobular, arcuate, cortical radiate, or radiate cortical, and then it breaks out into the afferent and the efferent arterioles, the glomerulus, and then the peritubual capillaries, which come down around the tubules, and they form vasa recta, and then the converse flips, cortical radiate veins, and all the way around from there. But we summarise that at the end anyway, so no need to worry about that for now. Course of urine distal to the major calyx. Again, I'm not really going to go there. The renal pelvis, it goes into the renal pelvis, ureter, where that first ureteric constriction is between the pelvis, uretopelvic constriction. Renal sinus is that expanded hilum. There's adipose tissue, there's lymphatics, all that. Adult renal blood flow is 1,200 millilitres a minute. It's 25% of cardiac output per minute goes through there, which is coincident with the brain. So at any one point, you've got 25% of blood supply per minute going through the brain, 25% going through the kidneys. So when you think about the fact that we've got, 4 or 5 litres worth of blood, and we're getting 25% through a minute, that's quite an impressive show for how often we pass things through the kidneys, and thereby how quickly, when the kidneys go wrong, our wet bed of functions can cause a problem. Arterial supply within through it, basically it's your renal artery, becomes a segmental artery, your interlobar, arcuate around the top, cortical radiate that gives the afferent, glomerular, efferent, then peritubule, for the juxtamedullary, which has a big loop of Henle deep into the medulla, almost toward the papillary duct actually. Those have vasa recta that come down. Loads of really good vector-based images for these online. I've got a lot of them here, to be fair. What is a renal lobe? So the lobe is the medullary pyramid and half of the column bilaterally, right? As well as that cortex. Okay, at the base of that pyramid. At the base, remember, these things arch to form the arcuate arteries, which divide into cortical radiate, giving off afferent arterioles, then glomerulus, efferent arteriole, peritubular capillaries. I don't know to what extent that's going to be clinically relevant. That's like microscopic capillary level stuff, maybe. Who knows? Why are glomerular capillaries unique? This is a nice little bit of news. Normally a capillary separates an artery and a vein, but it separates an artery and artery. Afferent and efferent with the glomerular capillaries in the middle. What do the afferent arterioles divide into? Peritubular. We get vasa recta for the juxtamedullary if it needs to get further down. And then they reunite cortical radiate veins, arcuate veins, interlobar veins, segmental veins, renal vein, all the way up into the venous system, into the right atrium of the heart. Nervous supply to the kidney, so you've got your renal ganglia through a renal plexus, right, into the hilum with the renal artery. So it's a periarterial plexus that runs through sympathetic, autonomic nervous system, nice regulation of vasoconstriction and vasodilation for the afferent and efferent to control filtration rate at the glomerulus. Two major regions of the nephron are the corpuscle, where plasma is filtered, and then the tubule, where that filtered plasma, which is now termed filtrate, passes through. What is the glomerular capsule? Bowman's. Right, so it's your double wall epithelial. You've got a parietal layer, you've got an inner visceral layer. What are the regions of the renal tubule? So we've got proximal convoluted loop, Henle distal. This is a cracker. I haven't actually seen a better detailed or colourful representation of Bowman's capsule than this from Tortora of 2012 or 09. It's 1 or 2 editions back. Now it's not that good. Tortora's gone downhill recently. They've truncated it. I think it's aimed more at medical school now than at AP students. So you've got simple squamous epithelium. Here you've got mesangial cells. You've got these podocytes. There's the proximal convoluted tubule. You can tell because there's a transition. So simple cuboidal is the proximal convoluted tubule and simple squamous is the glomerulus. Afferent arteriole, efferent arteriole. Note the sympathetic nerve supply to control it. This is the thick ascending limb. You can tell it's a thick ascending limb because the thin ascending limb is simple squamous. This is a simple cuboidal. You've got the macula densa, dense concentration there, and then you've got your juxtaglomerular cells there. Now the difference is two different functions. So your juxtaglomerular cells will secrete the renin, whereas the macular denser cell proper, so these macular denser cells, will sense NaCl, particularly when it's down. So it's hypovolemic states for which they'll release renin, which will upregulate the RAS system. So pause, have a look, labely. So cortex, right up there, convoluted tubules and corpuscles. Leukopenny descends down into the medulla with the collecting duct. Note the juxtamedullary nephron that's further down, so we need those vasa recta from the peritubule. So if you imagine that the peritubule has all of its peritubule things up here, it's going to need vasa recta to come down so it can reach. Yeah. What does the distal convoluted tubule empty into? Several of them into one collecting duct. So it's not one collecting duct per nephron. See all these different branches for the clear all. See all these branches for this. So that's loads of different distal convoluted tubules getting in there. So union of hundreds form a papillary duct. So loads of nephrons form a collecting duct. Loads of collecting ducts form the papillary ducts, which enter into the minor calyces, which enter into major calyces, renal, sinus, ureter. Two types of nephron, we've been over those. Ascending limb of the loop of Henle has both thick and thin regions. The thick region has a narrower lumen because it has columnar, simple columnar as opposed to simple squamous. That's a good example of the different arteries and veins. Nice there. There's an example of juxtamedullary versus cortical going further down. How does the arterial spine of the cortical and juxtamedullary nephron differ? Good question. So we've been over that. It's the vasa recta from the peritubules. Histological differences of each region, we've been over this as well. So the take-home message is in italics. Distal, DCT, and all collecting duct is simple cuboidal. So your descending and thin ascending is simple squamous epithelium, right? The simple cuboidal epithelium are principal cells with receptors for ADH and aldosterone and intercalated cells. Okay? We will get to those functions later on. This is a really nice example. You can see the parietal visceral layer. You can see podocytes. You can see a good transition here. So this is the glomerulus. So your parietal layer is formed of the simple squamous epithelium, right? That's simple cuboidal epithelium of the thick ascending limb. Macula densa, juxtaglomerular cells. So you can see the clear difference between these cells and these flat cells, for example, the difference between columnar and squamous. What is the macula densa? Those columnar tubules in the thick ascending crowded together. They also contain juxtaglomerular cells, which is the juxtaglomerular apparatus together. So 1 and 2 together. Juxtaglomerular function, we've been over this. It's renin, macula densa, boom. Are the kidney nephron numbers fixed? Yes, from birth. So destruction, kidney injury, that's why it's so bad. We don't have regeneration. What is the function of tubular secretion? To remove something from the bloodstream. So the tubule is secreting from its epithelium, from the basolateral to the apical surface, into the filtrate to be micturated out. So secretion is excretion. Okay? How are macular denser cells triggered? We've been over this. Decrease in blood pressure. So they then dilate, blah, 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 to modulate glomerular filtration rate in accordance. This is a summary of the blood vessels. Nothing we haven't gone over about 5 times already. Sweet, and there's your questions. Thank you very much.